Hi everybody, and welcome to our Educating and Empowering You program for the month of February. As you can imagine, this is our Heart Month, and so we thought that the best person to help us with Heart Month this month would be Dr. Sarda with Iowa Heart. And I'm Sarah Klutbane. I'm the Foundation Director for Boone County Hospital Foundation. We host these programs monthly, and we're able to obviously provide these on the internet and record them for people to watch at a later time. It seems to work very well. So I'm just really pleased to have Dr. Sarda here to walk us through some new information. We'll definitely hit on some COVID information, which I think a lot of people are going to be very interested in. And we'll get started by I'll turn it over to you, Dr. Sarda, if you don't mind just maybe giving us a little bit more background about yourself, and then we'll dive in and I'll ask you some questions.
So I'm Rakshak Sarda. I work for Iowa Heart Center. My main office is Ames. And I also do teaching service, teaching fellows, medical residents, medical students in our Mercy Hospital and also here in Ames office. I have multiple board certifications, including internal medicine, cardiology, advanced heart failure, nuclear cardiology, echocardiography, hypertension, CT, vascular medicine, I don't know. So I also come to Boone County Hospital as in my outreach clinic for many years now, and I see Sarah there many times in the hallways, and we have done these programs in the past. So I'm very happy to join this program. Let's start.
Okay, wonderful. Well, it seems as we've already had a discussion before the program got started that so many people come to you, Dr. Sarda. So I'm curious, do you know off the top of your head how many patients you have on a given time frame? I mean, but obviously you're going between Ames and Boone. Do you see 50, 60, 70 patients a week, a month? How does that work for you?
Sandy may answer that question better, but I think it will be around 50 to 60 patients a week, at least 60 patients a week we see.
Yeah, and that's amazing. I mean, again, it just is a testament to you as a physician, and also just the fact that so many people do rely on Iowa Heart for your services. So as we get started today, we are looking at just give us a general kind of overview of just some things that might be happening when somebody might want to come see you. So maybe they're experiencing high blood pressure, or maybe they have started having some heart palpitations, or whatever the case is. Can you tell us just a little bit about, what that kind of entails in terms of seeing those types of patients?
So Sarah, can you be a little specific on this question?
Sure. Well, the question was mainly around high blood pressure and just the concern of high blood pressure, and maybe, what would be the ideal the ideal blood pressure, but then also how does that kind of play into heart health?
So Sandy, our office manager, just sent out this thing that we see, each of us see around 100 patients a week.
Oh, wow.
So I see around 100 patients a week.
That's amazing.
So this is a very good question, and high blood pressure is a major cardiovascular risk. And as our population is aging, we see more of high blood pressure. The high blood pressure disease of lifestyle. So we are seeing as the obesity increasing, as the salt in our diet increasing, the blood pressures overall are increasing. I did recently a seminar with our nurse practitioners and other nurses, and we did talk about hypertension, and there are a lot of changes which has been happening in hypertension field. Just on a footnote, I am also a hypertension board certified physician, so I get a lot of consults for hypertension management as such here in our Ames office. And it is a difficult disease to control. And as the numbers go up, the risk increases, the risk of heart attack, the risk of stroke, the risk of kidney damage, the risk of eye damage, they all increase. So we want the blood pressure numbers to be low. And most recently, where cardiologists differ from family practitioners is we want the numbers to be low. So our numbers in most cases are less than 130, which is the top number, which is called systolic blood pressure, and less than 80, which is the bottom number, are called diastolic blood pressure. So less than 130 over 80 is our goal in most of the patients, except for very elderly or patients who had stroke or have balance issues and other things. So what is the lowest number they can go? And usually we say that if you start having symptoms, fatigue, tiredness, dizziness, then it is a low number for you. So the lower number is mainly by symptoms. We have patients with heart failure whose numbers may be 90 over 60 and they do well. But then our patients don't do well at 100 over 70, then we want to tell them that, okay, keep your blood pressure around 110 over 70, which makes you feel better. But lower the number are, and I think our goal should be in most of our patients 110 over 70, so that they don't have symptoms. They have room to go up or bottom a little low and have the best outcomes. There are a lot of research studies on that, and that's where we come with this number. But if you don't feel well with lower numbers, then we can decrease your medications and get the blood pressure a little up so that you feel better. The whole idea is to make you feel better. The other thing, Sarah, we need to stress is hypertension is a silent killer. And sometimes your blood pressure is high and you feel okay. That doesn't mean it's okay. So you need to keep your blood pressure numbers 130 over 80 or below.
Okay, that's a great thing for us to all be very aware of. And do you suggest that people check their blood pressure fairly often, or what would indicate that they would need to check their blood pressure for hypertension?
So most of the time, we like our patients to check their blood pressure at least once or twice a week. If you're on high blood pressure medications and if you're not feeling well, check your blood pressure. So make sure it is not very high, not very low. In usual, if you can check it once a week, if you have risk factors for hypertension like obesity, family history, you're not exercising that much, then you or age, then you can check your blood pressure once a week. And if it is good, then you can check it once a month. But if you're on blood pressure medications, frequent blood pressure checking once or twice a week is advised. Now, Sarah, we have a lot of patients who get nervous and anxious, and they check their blood pressure 3-4 times a week, 3-4 times a day, and they get nervous if the numbers are a little high. And then that causes their blood pressure to go further high. Now, these patients are not too many, but they are out there. And if you are one of them, then you don't have to check your blood pressure too often if it makes you anxious and if the subsequent readings you see are higher. In those patients, once we have a good medical regimen that controls their blood pressure overall okay, then we want them to check once or twice a week.
Okay. And then is that a consistent basis, like every Monday at noon and every Thursday at noon or something like that? Or is there any type of formula around that?
This is a very good question, get asked quite a bit. And I say take it into every situation. So one day you are in the morning, one day you are in the evening, one day afternoon, after lunch, after dinner, whatever. So you have different readings of different circumstances. So there is no good formula that you should check it every morning.
Okay, great. Well, in this, I don't know if this is correlated or not, but one of the other questions that was sent to us was around taking a daily aspirin and what your recommendation is for that.
This is a very hot topic right now. And taking daily aspirin recommendations have been off and on over the years. I started my med school in 1985. So I'm dating myself. 37 years ago, I started my medical school. And since then, I have at least 15 times gone back and forth on should we use daily aspirin or not. So nowadays, if you do not have established coronary artery disease, if you do not have many risk factors, then they prefer you not to take aspirin as prevention because it increases risk of bleeding. It does not help. So previously, everybody was taking an aspirin, Bayer aspirin. There were a lot of TV ads and everything. But nowadays, if you have to take aspirin, please talk to your doctor, your cardiologist, and they can assess your risk. That if you are low risk, moderate risk, or high risk. If you're low risk, usually we do not put you on aspirin. Moderate and high risk, depending upon the situation, your bleeding risk, other medications, we suggest you to take aspirin or not. So aspirin is very potent medication. It can cause bleeding. It can cause complications. So be very careful of not to self-medicate yourself with aspirin. The other thing, Sarah, we see is a lot of people take aspirin for pain relief, and that increases the risk of bleeding. So a lot of medications have aspirin. So make sure you do not take aspirin. There are other pain medications. As you get older, if your weight is low, if you are females, your risk of bleeding increases. And we see a lot of bleeding related complications simply on aspirin in our practice.
Okay. Okay. So it sounds like the message there simply is just to make sure that you've talked to your doctor about it before you're just doing it on your own to take an aspirin. That's
Yes.
fair. Yes. Okay. So going into just a little bit about, if we were to come visit you in the office for an appointment, do I need to bring my medication bottles with me, or how do you suggest to your patients to best inform you of what they're taking and how often?
So medication and medication reconciliation is a problem all throughout the world. Patients will tell, okay, I'm taking the same medication as I was taking before, but there are multiple providers, there are multiple doctors, there are multiple pharmacies. Patient go to the hospital, get a different medication list and all that. And it is extremely important for your physician to make decisions to know what medications you're taking. Please bring your medication bottles and exact bottles what you're taking. Now there may be pill packs, there may be blister packs. Bring them so that we can read through what is in them. Sometimes they will tell me take a colored pill, pink pill, or a green pill. Because the manufacturers change, the pharmacies change, it's very hard to figure it out what medication you're taking from simply the pill color. And the dosages also change. Extremely important. And now you will see that we have healthcare personnel shortage all over the country. The staffing is a big issue. And if you can help us out, sort out what medications you are taking exactly, it will save a lot of time and save a lot of errors. Many a times after the visit is over, we find out that the medication list was incorrect, and then we have to do something about that. We call patients, try to figure it out, and that takes time and also increases the risk of errors. And as you all know, medical errors are one of the biggest problem we have. And if you do not know exactly what medications you're taking, the chances of errors increase. Please bring your medications when you come to the office. Or
Yeah.
exact list. Sometimes they bring in a list, and that is not correct because the medications they are taking are different than the list.
Mhm. Yeah, that makes a lot of sense. I mean, it would seem a little bit like it would be challenging for you as a provider to have all those bottles there, but in the end, it actually is going to be quite helpful because you know exactly what they're taking and exactly what the dosage is, and there's no, like you said, room for error in that process. So that's great information to have that and to know that. So if someone were starting to experience some heart issues, or perceived heart issues, what signs are they looking for that there might be something going on with their heart?
So, Sarah, we should divide this into two. One is, what is the emergency? When should you call 911? And one is, when should you call your doctor, get an appointment, which may not be like you going to the ER. So first, when to call 911. If you are not feeling well, you are dizzy, somebody has passed out, you are having chest pain, the pain is not going away, you are having sweating, and we'll go on the chest pain a little bit more. You cannot breathe. Things are not right. There's impending doom, and you cannot figure it out most of the time. Even I cannot figure it out with all those symptoms. So call 911. That may be one phone call which will save life. If a healthcare professional, an EMT tech, reaches you, they have a lot of equipment they can help you with if you are in a life-threatening situation. So please do not waste time and call 911. Now, I understand that there may be sometimes false calls, and you may not understand, and you may get to the ER and they will say everything is fine, but that is okay. But we do not want to miss an opportunity of saving a life. So that is one thing. So again, chest pain, which is not going away. And I'll go in detail about that. Shortness of breath, dizziness, passing out, extreme perspiration, extreme fatigue, feeling of impending doom. And if you see somebody who is not mentioning these things, but if you see something is wrong, then you, as a bystander, can also make that phone call. Now, when we say chest pain, and when you come to our office, they will ask you, do you have chest pain? That is a very broad category. You may have chest pain, you may have chest pressure, you may have heaviness, you may have tightening, you may have back pain, pain between shoulder blades, pain in your shoulder, pain in your arm. It's not going away. It's something different. You don't have an explanation to it. So just chest pain, which is our common parlance, but maybe all these things which I'm talking about. So look into that. And sometimes the presenting symptom may be extreme shortness of breath. I cannot walk from my bed to the bathroom. I was fine, but now I cannot do it. So that is a very important sign, and you need to seek help right away. So those are the emergency situation, and there can be multiple things. One thing, you know your body the most. Out of 7 billion people, you can understand your body. A patient can. So if things are not right, please seek help. Please don't try to diagnose on your own. Seek help, and that will save a life. Now, we get a lot of patients who wants to see a doctor. We all, including me. And that is where the symptomatology is. So you are exercising well, and all of a sudden you start realizing that now when I go 2 flights of stairs or 3 flights of stairs, or I went for the basketball game and I could not get up the bleachers or could not get up to my seat. I was doing my yard work, but now I cannot finish it up. I was exercising for this long, now I cannot do it. I get short of breath, I get chest tightness. And other thing is the heartburn. I forgot in the heartburn symptom. You can have the same symptoms of a heartburn, but many a times a heart attack is missed because this is heartburn. I'll take Tums, I'll take a Prilosec and it will go away. And usually the heartburn is coming from the heart. And in this case, if you start doing something, you start having these heartburn symptoms, seek help. And these may be indicators that there is some heart disease going on. Other thing which you may notice is swelling over legs, increase in weight, and you will see maybe your abdomen is increasing, your rings are tight. So if you start having some swelling, it may be a manifestation of heart disease. Now, it may be there may be other reasons for that, but that may be a manifestation of heart disease. And when I say about manifestation of heart disease, maybe blockages or maybe weak heart. And weak heart is called cardiomyopathy, and that is the commonest thing. I'm gaining weight, or I'm unable to walk, or I'm getting short of breath, or I'm dizzy. So these are the symptoms of weak heart, and you need to seek help because there are a lot of therapies available, and we can really help patients in this regard.
Okay, excellent. That's very helpful to identify the difference between calling your doctor versus calling 911. And, one of my fondest memories of the first time that you spoke at our Educating and Empowering You program was that you said to everybody, I think it was something along the lines, if everybody would just take time for mindfulness and meditation, you wouldn't need me. And I think that that's leads me into my next question about stress and heart disease. And maybe you can share a little bit about stress and heart disease and maybe some ways that we can help ourselves in terms of stress.
So Sarah, as you know, we have over the years multiple discussions on this regard, and in the hallways also we have discussion. And you yourself being a practitioner, you understand the complexities of these things. Now, there are multiple study papers and publications now coming in about stress and heart disease. The biggest problem with the stress is we do not have any measuring tool, a good measuring tool in our offices. There are certain questionnaires and all those things, but they are not very good measuring tools like pulse or blood pressure or temperature, height, weight like this. The one thing which I want to first say is stress-induced cardiomyopathy, and it used to be called Takotsubo cardiomyopathy, but let's not get into that. But severe stress can cause your heart to get very weak, very fast, and that may end up in hospital. Good news is that improves quite a bit, but bad news is if you do not reach the hospital, then it can be a very serious situation. So that is usually with extreme stress, and that is called stress-induced cardiomyopathy. The other thing about stress is stress causes chronic inflammation, and chronic inflammation causes coronary artery disease. Now, I grew up in India, and you would be amazed to know that if you're an Indian or a South Asian, I should say South Asian, and if you live in developed countries like Canada, America, in England, there are certain studies about England, that the risk of heart disease is very high in people like me. And they try to figure it out. We eat healthy, we are thin, we are not very obese, we exercise and all those things. So what is that which causes this immense heart disease in young people from South Asian descent? And everybody points out to stress. And that's where this whole thing starts, that everybody's having stress. And stress can cause chronic inflammation and cause premature coronary artery disease, and which can lead to multiple complications, including heart attacks, which can cause weak heart. And, some people, unfortunately, will also die from these problems. So we are, in our practice, always talking about reducing stress and meditation and other things. The other thing which we all have to understand about stress and arrhythmias. So a lot of patients can get stress-induced atrial fibrillation, and there may be multiple explanations for those. Third thing is stress causing high blood pressure. And high blood pressure, as we talked about, causing heart disease and strokes and kidney damage and all those things. And there's a direct correlation of stress and high blood pressure. We see even little anxiety like white coat hypertension. They come to a doctor's office, their blood pressure is high. These people are very prone to having other stress events in their life and have these fluctuations in blood pressure, fluctuations in a lot of other neurochemicals in their body, which can increase their risk of heart disease. So we talked about weak heart muscle because of stress. We talked about high blood pressure because of stress. We talked about arrhythmias because of the stress, and we talked about heart attacks because of the stress. If there is anything else, I think it will be there. It causes fatigue and tiredness. You are stressed out. It's like you ran a marathon, because all your body is so much in tens, the muscles work, you have aches, pains. So if you want to do anything for your good health, the first thing starts with good mental health, good mental status. Do meditation. Ask Sarah how helpful it is. And there are 100 different types of meditation. You pick up your liking. You don't have to follow anybody's. You pick up your liking, and that will be a key. I I personally know how helpful it is. And I'm going to share a personal note here. I went for a 10-day retreat for meditation. It was free of cost. It was non-denominational. You only donate money if you want to. And for 9 days, we were not allowed to talk to anybody, make even an eye contact with anybody. No phones, no TV, no nothing, totally out of. They will give you 2 meals and you meditate, and they help you how to do it. Those were the 10 best days of my life. I'm 53 years old. Those were 10 best days of my life. So it is really, really very helpful. Please try it. It will improve your health, overall health.
And that's why I enjoy hearing you talk about it. I think that I can appreciate it. And I think so many more people are seeing the value in that downtime and having that introspective time, or just time to, I mean, we're in this fight or flight kind of constantly, right? That's kind of what you were referencing. And just by having that opportunity to turn off the screens, turn off things and all of our things that are kind of inspiring us, I guess, for lack of a better term, around us, that we kind of can just take a few moments to quiet the mind. And I definitely can appreciate that. And I think that there are more and more studies that are helping us understand how that works, and from a from the neuro side of things too, and then connecting the heart and the vagus nerve and all those fun things. So definitely a passion of mine as well. So that leads us into just talking a little bit more about, it sounds like there's a new drug out, perhaps, or new blood thinning drugs that are being used in place of Coumadin, and just maybe telling us a little bit of the pros and cons of those.
So there are 4 drugs which have been now in market for a long time. 3 of them are used most common, and their market names, the brand names, which you would understand better. And I don't have, Sarah, I think I should say that I do not have any financial interest in any of those, whatever they call it, financial disclosure. They are Eliquis, Pradaxa, and Xarelto in alphabetical order. And they are what we call an oral anticoagulant, like as warfarin, but they directly affect the blood cascade. Warfarin acts by decreasing vitamin K dependent factors, and they directly affect the further down the chain. So in that event, these 3 new blood thinners which we use here quite often, we do not need to check INR. For warfarin, we need to check INR to see how thin your blood is. So these have shown that they are as good as warfarin. All the studies were done as non-inferiority, means they want to check that it is as good as warfarin, which it turned out to be. And then they did the future studies, and they think that in some cases it is better than warfarin. But it is easier to take than warfarin. Warfarin has a lot of drug interaction, means you can take certain drugs, and if you take certain drugs, your numbers can go up or down. You have to be very careful about what you eat, how much you eat, all those kind of things. And the numbers go up and down about that. In these newer drugs, you do not have to worry about most of the drug interaction. There are some drug interactions, and you do not have to worry about what you're eating. You do not have to check your INRs on regular basis. And they are pretty good. They are pretty good. They are as good as warfarin or sometimes better. The problems which I see with these medications are they're very expensive. They're extremely expensive. And when you have to take these medications every day for the rest of your life, in most of the cases, it can really add up. The second thing is we have patients on other expensive medications, so their bills go tremendously high. Third thing is most of the time these are used in seniors who have limited income and other issues. So we have to be very careful about what medication cost for one particular plan. And at Iowa Heart Center, we are very good about it. Whatever your plan covers, we would try to switch you to that medication if you can tolerate it. There is no one better than other. And we are very open about it. Apart from cost, there are certain issues about if you start bleeding, then to do a reversal of the bleeding, the medications are present now, but they are very expensive. And we do not need to do that very often. Once a year or maybe less than that is the situation where we have to do give certain medications to reverse those effects. These are good medications. They are used worldwide. And for me, at this time, only the problem is the cost. Once they become generic and they become cheaper, warfarin would be used very little. One group of patients where we have to be careful about these medications are people who have kidney issues, who have kidney failure, renal failure. That's where we use warfarin quite a bit. And sometimes when you are bleeding and we cannot get an appropriate dose and do not know where your blood thinner effect is, they will change it. Otherwise, they're good medication. Sarah, does that answer the question?
It does. I was just going to ask from a layman's perspective, like myself, can you clarify warfarin and Coumadin? Is that the same thing or two different medications?
Thank you. Coumadin is the brand name. Warfarin is the generic name. Warfarin and Coumadin are the same. Sometimes you'll hear Gentavin. Coumadin is like Xerox, everybody says like Coumadin, although the generic. So yes, Coumadin is brand name, Warfarin and Coumadin are same. Yeah.
Okay, thank you. That was the only question I had from that. Otherwise, that made perfect sense. So this leads us into the last part of our discussion, which I think is going to be something that's going to be very interesting for people to hear you talk a little bit more about COVID and how it has affected the hearts of people who have had COVID once, twice, maybe even 3 times now in this process. And I have more questions along those lines, but maybe you can just get us started at least with your what you're seeing.
So it's now nearly 2 years since the pandemic started. And the first cases of COVID happened in 2019 in Wuhan province of China. And we started knowing a little bit about it in January. We said that, oh, it's going to come to us, and all those questions started. And then we started seeing deaths in Wuhan, and then it hit Europe, and then it came to us. And it's a terrible disease. 900,000 people in America has died. Worldwide, multiple deaths have happened. We do not know a lot about COVID yet. So we started seeing that COVID from heart standpoint of view, from cardiology standpoint, where we get consulted was initially it was the heart attacks. So people who were having COVID were also having heart attacks, and this was attributed to blood clotting. And the same blood clotting we saw with a condition called pulmonary embolism when the clot goes into the lungs. And those people, we were seeing quite a bit of people having pulmonary embolism. So it was causing clots, including heart attacks, pulmonary embolism. Strokes also were reported with this thing. Then we started seeing that people started having weak heart, or called myocarditis, or inflammation of the covering of the heart called pericarditis. And again, it was attributed that it may be related to COVID. Very hard to prove, but because it was happening in the situation of COVID, most likely it was one of the manifestation of the COVID. And these were the initial viruses, and then we had Delta variant, and now we have Omicron variant. So some situation has changed according to the variants of the COVID-19 virus. Mainly, these were the three things which we saw, which were the heart attacks, myocarditis, pericarditis. And then when you have a weak heart or when you have a heart attack, you also have arrhythmias. So a lot of people had died of arrhythmias, but most likely there may be something else going on with them. And things were happening so fast. The data was so fast changing that not very clear-cut information was that. But now there is good information that these things are directly related to COVID infection. Now we're talking about COVID infection. And these are the heart-related issues. These are very serious, by the way, these are very serious issues.
Mhm. Yes, absolutely. So are you seeing more?
Sarah,
Sorry.
one more thing I forgot.
Sure, that's
Now,
okay.
most of the consults we got and still getting on COVID patients are people who have lung issues, who have COVID-19 pneumonia, and their lungs are very, very damaged, and they get into what we call respiratory distress or respiratory failure, and which causes arrhythmias. And mainly the arrhythmias which we have found are atrial fibrillation. So very high number of cases of atrial fibrillation, which were related to COVID-19 pneumonia, we are getting it. Thank you. Now, I'm sorry, you were asking the
Oh,
question.
that's okay. That's okay. It was just along those lines. You kind of already referenced this cardiac events after COVID. Is there a percentage that you've even come up with from maybe your own patient base or anything along those lines that you would have any more detail on?
The percentages are a little bit complicated thing here because what we are seeing is mainly the people who were hospitalized. And there is this whole idea of how many people were hospitalized. And last 1 year, or a little bit more than 1 year, we started getting vaccine. And the whole situation changed with who is vaccinated and who is not vaccinated. And the complication rates were happening in mainly in people who were not vaccinated. And people who are vaccinated were having less complications. So I do not know the exact details of our hospital, but there was a time when we were getting 20 to 30% of our COVID patients, we were getting consulted for one or the other reason. Usually it will be less oxygenation, atrial fibrillation, cardiomyopathy, heart attacks. So 20 to 30% of our patients, it seemed like that we were getting consulted for. Now, again, these are all admitted patients. Now, I still see patients who will say, I'm not the same after I had COVID 1 year ago. I do not know the explanation for that what it means. But they do come, we check their hearts and other things. We were also looking into some patients with echocardiographic techniques, newer echocardiographic techniques, like strain rate imaging and all those things. I do not think we have any good data yet regarding those things.
Yes, and I think that it was Mary Greeley was posting their daily, or I think every week they were posting their patient census for COVID patients that were in the hospital. And I did watch it, so this, isn't a technical percentage, but it seemed like maybe about 25% of those in the hospital had been vaccinated versus 75% who were in the hospital were not. And then there was a time where actually it was about 50-50, which I thought was interesting, 50% of each on each side, but I think everything's starting to slow down a little bit more. And are you seeing that as well?
It's a very astute observation, Sarah. If you look into the initial data, it started with, and these were very sick patients, hundreds of patients at Mercy Hospital. And it started with 95-5, then 90-10, and 85-15. So initially, most of these sick patients were unvaccinated patients. They were very sick. There were a lot of patients dying. I have seen a lot of that. These have been very hard 2 years. And most of those happened with unvaccinated, young people, unvaccinated people having a lot of complication. Now, you are correct. We have Omicron is not that serious as it was Delta, but it's still causing issues. We don't know the long term, so we still want people to be vaccinated. And then there was this whole divide about vaccination and masking and all those things. So there was, but now overall the numbers are down, and we are not seeing those sicknesses where a lot of people intubated, nurses working to exhaustion. Here we should take a moment and thank all our staff at the hospital. I can tell you, doctors are the least people in terms of time giving to the patient. Our nurses, our technicians, our environmental services people, dietitians, echocardiographers, X-ray technicians, now everybody, each and every part of that hospital, they did a tremendous work. We should give them that respect, the recognition, the thank you. They did a wonderful job. So we should all patients, all physicians, all other staff should give them this big thank you.
Yeah, I agree 100% wholeheartedly. I think that all of our healthcare providers over the last couple of years have weathered some pretty intense situations, and it's speaking of stress, going back to the stress factor. I mean, they've been under a lot of stress and a lot of pressure for many different reasons. But yes, I agree. I think
Think about our greeters. They don't know what the status of the person is. Somebody is arguing with them for the mask or for this or for that. The patient visitor restrictions, and our greeters of the front staff, they are our front line. They are our front line. They are taking all the bullets. We should thank them. Nothing is enough. You should thank them every single day.
Yes, I agree. And I think that's a great message to send out to our community to do that as well. So just a couple more quick questions about COVID. This is kind of an interesting flip-flop of, would somebody be more likely to catch COVID if they had heart disease versus someone who wouldn't have it?
So I do not know if we should go into vaccination debate or not, but you should get vaccinated. I got vaccinated, my wife got vaccinated, our 3 kids got vaccinated, most of my colleagues got vaccinated. And the reason being is we saw the difference between vaccinated and unvaccinated. Now, vaccination does not mean that you will not get infection. You'll still get infection. We all will get infection, kind of thing, if it persists for long. It is that it gives you chance of fighting that infection better. The other thing is who is going to get sick and who is not going to get sick. I don't know. You flip a coin. I have seen people who are in perfect health. One of my friends, he was a cardiologist, professor of medicine and preventive cardiology, ran marathons. And he contracted COVID before vaccination and he died. So, and this is not anywhere, but this was in Midwest in Ohio. And what do you say? Perfectly fit guy, he died. So it's very hard to say who will get sick. And my 93-year-old mother-in-law did okay with COVID. She has some cough, but she did okay. She survived. So people who contract COVID, who have underlying health condition like cardiomyopathy, like sleep apnea, like obesity, like hypertension, like diabetes, like COPD, they have more chances of having complication, including death. Contraction, maybe they're still the same, but somebody has a very good immune system, has been vaccinated, the virus comes, it touches them, they are sick for a day or two, and they are back to normal, versus somebody can be sick for 15 days or so. I have done, in my previous careers before coming here, I was also did my post-graduation in preventive and social medicine. And I used to go for a lot of vaccination drives, and we would have these questions all the time from illiterate people. that, okay, what will this do and not do? But this really helps. And people who are at high risk should take all the precaution. I think masking should still be uh, utilized. We are utilizing it less, but I think it should still be utilized because your risk of contracting the disease would be less and complications would be less. So people who have heart disease do worse with COVID infection, but getting the infection, like you will get the infection because of heart disease, not. You have to get the virus from somewhere. So it's a community spread. You can get virus. Everybody can get virus. It's the effect of the virus on weaker immune system, weaker hearts, weaker body.
Right. And even as you mentioned, a little bit of the roll of the dice in there too, that somebody who appears to be very healthy could also have extreme effects from it as well. So, like you said, I think earlier too, that we know very little about it and about COVID and that we're still learning all the time. So one of the other questions, this actually leads back to the aspirin question. Is this something that is recommended after being positive for COVID?
So there was this issue, and we talked about it, people having blood clots. And the biggest problem we were having was blood clots. But then there were some pulmonary contusion and all those things. So again, there is no real good recommendation, but we personally, I tell people at least take one month of aspirin after you have COVID infection. And if you're obese or if you have other risk factors for blood clots, like if you're on an oral contraceptive pill, if you have a history of cancer, all those things, and you don't have risk of bleeding and you're not on other blood thinners. The biggest problem is if you're on warfarin or if you're on this newer medication and your doctor has want you not to take aspirin and you start taking aspirin, by my this comment will be bad. So if you are at a very low risk of bleeding, and if you are not at a risk of having interaction, I tell my patients right now, take for a month of aspirin. Do I have any good data? No. It's my gut feeling that if they are dying of clots, at least there will be little less chance of clots.
So a month after.
That's what I'm saying. But
Yep.
Sarah, I do not have any data to back up my claim here. So as you get older, as you get gray hair, as you get this baldness, you pick up some things, and this is what I have picked up.
Well, I think that we trust your judgment that you've proved yourself over the last, would you say, 37 years that you've been in practice, that you
Not
do.
practice. I started medical school.
We started medical school. Okay, well then we
Okay.
won't go 37 years quite yet. But needless to say, we just have a lot of respect for you and your wisdom and your experience, and so many people that I think all of us can attest to having somebody that has come to see you as a patient in our families. So thank you for your time today. It's amazing how fast time goes and how we could probably continue to keep talking. I don't know if I think if we have a few more minutes, if there's anything else you wanted to add, or if any of our folks out in our audience had any questions that we didn't address. If there's anything remaining, we have a few minutes.
So, Sarah, I want to thank my patients. Our patients make or break you. I cannot thank our staff enough every single day. And the patients make and break you. They follow your advice, they treat you well. And when we go home, we think we have accomplished something. And that's what makes the life wonderful, fruitful, worthwhile, and want to come next day to work. And I simply enjoy it. I absolutely enjoy it. This is my picnic. Uh, I I don't get stressed out at work because I really enjoy it, and it comes from the patients. And what Denise said about Marvel, and now I started thinking about her face and all those things, and the visit and all those, and that makes your life, that makes your day. So thank you very much, and wherever there is body, there will be sickness, and we are in this game together. And you have sickness, you seek help, and we take care of whatever we can with God's grace, your health care, and we feed our families. We make a living doing that.
Yeah.
So thank you very much. We are here because of you.
Thank you. And again, you're a practical, down-to-earth practitioner of your specialty, and we're just so grateful that we get to have you come over to Boone County Hospital. So do you mind sharing also quickly what typically your schedule is? I think you're over here a couple of days a month at least. Is that right?
Sandy, are you on call?
I am. Yep. Dr. Sarda is scheduled there usually anywhere between 2 and 4 Thursdays a month.
Okay.
But it's always on Thursdays.
Okay. So they can contact you at Iowa Heart then, is that best, or here at our specialty clinic at Boone County Hospital, which is better, Sandy?
Actually, if you call the office at Ames, that is the best way to get on the schedule. Although if you call over there, I'm sure Heather or one of the gals will get the information over to us. But if anyone wants the Ames phone number, it's 515-232-2500.
Great. Thank you for that.
And we do see inpatients also. So when I am there, and if there's any inpatient, we do see inpatient consults also. And most of your physicians there know that if I'm there or not. And if they just give us information that there's a patient to be seen, we'll see them. If I'm there, we'll come and see them. It doesn't matter.
Okay. Fantastic. Well, thank you again so much for your time today, Dr. Sarda, and we hope to have you back maybe this time next year with some maybe even better news about our progress with COVID and all the things that are happening, and maybe we'll get a few people to start doing some meditation practice. They can come back and report in next year too. So
Sarah, thank you for the opportunity. I really enjoy these events. Thank you.
Thank you. Appreciate it so much. Take care.
Take care. Bye.
Bye.